Okay, thank you. So, yeah, we'll take over the presentation of Juan Sierra. It will deal about post-procedural care after atrial fibrillation ablation. Okay, so as electrophysiologists, we love atrial fibrillation ablation. We want to be more efficient at it, perform safer procedure, getting faster. But maybe sometimes we focus a bit too much on the procedure itself. And I can imagine from a perspective of the general practitioner or the referrals, from their perspective, the procedure itself might be just a short-term thing within the timeline of the patient journey with atrial fibrillation. So there is a lot to discuss before the procedure, and perhaps even more after the procedure, things to manage and to evaluate. So let me provide you an update and some new aspects about the post-procedural care after atrial fibrillation ablation. And the first thing after atrial fibrillation ablation is, of course, to get hemostasis. Classically, we can do this by manual compression. Once the activated clotting time is below the 250. And protamine can accelerate this hemostasis. But there is now also a new feature in the last years, and that's the figure of 8 suture. We do it also more increasingly. This makes the compression manually unnecessary, so it can reduce cath lab time. Another quite new concept is the concept of same-day discharge protocol. At our center, we still do it with an overnight stay after atrial fibrillation ablation, but there are some centers that have this experience. This is a meta-analysis of some studies. You see in general that they were successful in more than 80% of the cases, of the planned cases, to get patients discharged in the same day. And also they get actually, if you see that the 30-day complication rate or the 30-day readmissions, they were not different between the same-day discharge protocol or an overnight stay. But if we look at the study with the biggest experience, the inclusion of the biggest number of patients, then we see that it appears feasible and safe, but it's more so in selected patients. It's the patients that are sicker, that had a previous stroke, diabetes, COPD, or coronary artery disease. We saw that were predictor factors of early readmission. So these were things still to manage before discharge. Let's proceed to more important things at the distance of the discharge. So, and there's of course also the anticoagulation therapy that needs to be included. So what we can say in general is that early after atrial fibrillation ablation, all patients, regardless of the SHATVA score, so regardless of their underlying stroke risk score, they should have anticoagulation. This is without discussion. If we look beyond these 2 months after the procedure, then it's more controversial, but the consensus is still to base ourselves on the patient's stroke risk. Because we know that, in general, patients with atrial fibrillation, regardless of an ablation they underwent or not, they are at higher risk of stroke. And we know that the event rate of stroke without oral anticoagulation is much, much higher than the bleeding occurrence of patients with oral anticoagulation. So there is a net clinical benefit. And so if we look, and this was, this was more so in patients with a SHATVA score of 2 or higher. What now for to discuss continuation or discontinuation of oral anticoagulation after atrial fibrillation ablation. Well, there is not yet a randomized controlled trial. There is something ongoing, the OCEAN trial, evaluating patients with SHATS-VAS score of at least 1, who were they didn't have recurrence of atrial fibrillation after 1 year, and they were randomized between aspirin and oral anticoagulation. So what we only have till now is registry data. These of patients in Sweden after PVI, and there we could see that patient that stopped the warfarin after ablation, they got a high risk of stroke in patients that had SHATS-VAS score of 2 of higher. So the consensus is still to not discontinue anticoagulation in this higher risk patient group. We can discontinue anticoagulation in a low risk patient group at 2 months. This is the SHATS-VAS score 0 in men and 1 in females. And this is regardless of the outcome. The patients with intermediate risk, SHATS-VAS 1 men and 2 for females, we can consider to stop it after 12 months. But there is, and then we have to be sure that there is no AFib recurrence. So let's move over to another topic. It will be about outcome efficacy. But I will concentrate only on one thing, on the blanking period. I think it's an important thing to judge from when on we can judge our ablation to be effective or not. So the blanking period is a period during which any type of supraventricular tachycardia is not considered a recurrence. Typically, historically, this was a 3-month blanking period. And where this 3 month came from, nobody knows really. But it seems that it was a division in 2 of the 6-month blanking period after surgical atrial fibrillation ablation. But this 3-month blanking period might not be the real thing. So what we know also is that the incidence of early recurrences, the ERAT, depends also on the type of monitoring protocol. That might vary if you do only intermittent monitoring or continuous. But more importantly than the type of monitoring, I think, is the timing. And this is a study of our center, patients with paroxysmal atrial fibrillation that underwent cryoballoon. Intermittent monitoring, 24 hours Holters, and symptomatic registration. And we see clearly that patients that had an ERAT, an early recurrences, after the 6 weeks, they had systematically also later recurrences. So this was a paper of Giacomo Mugnai. So this was intermittent monitoring. If you look at more recent data in continuous monitoring evaluation, a sub-analysis of the CIRCADOS trial, we see that, of course, we will be more sensitive. We will pick up more ERAT. And if we do then a ROC curve, so we maximize sensitivity and specificity, it will be around 20 days. But if you see at 20 days, you will still have a specificity of around 75. So 1/4 of the patients you will unneeded, you will wrongly categorize them as having a real recurrence. So you won't have actually more specificity. And then you go up to more than 90%, then you are again, again in the 40, 50 days after procedure. So that corresponds nicely with the previous paper, I think, of our group. Previous studies were evaluated in radiofrequency and cryoballoon ablation. If we look now at pulse field ablation, then the blanking period might be even shorter. This is a paper showing that recurrences in the 2nd and 3rd month after ablation are really highly associated with late recurrences also. So in pulse field ablation, this blanking period might be only 1 month. So 1 month for pulse field ablation, 1.5 months for radiofrequency and cryoballoon ablation. So after that period, you can safely say that if the patient does a recurrence, we will also have a late recurrence, so we will have a failure of our ablation procedure. And what's the management then? Well, I think we have to rediscuss reablation and at an early stage, and we see that the results of that are really good on the long term then. Okay, let's move to the last topic, the complications. I know that recently we decrease the number of complications, and but I think it's still important to tell this. We do more and more procedures. We do it also in sicker populations, patients that are older. So I think referrals, GPs, they need to know, they need to be aware of this also. To say that the majority of the complications occur in the first hours after ablation procedure, but delayed complications that can be even life-threatening can also occur up to weeks after it. So I'll go over it quickly. One of the most frequent life-threatening complication is cardiac tamponade. The mechanism is a direct trauma, misdirected transeptal puncture, but can also be due to energy delivery, overheating, excessive force or temperature with radiofrequency ablation. And this in combination, of course, with the anticoagulation we give during the procedure. Important to say that the presentation can also be delayed, and aspecific, so it's not always the image of shock and hypotension. Patient can present also delayed in emergency department with thoracic pain, dyspnea. Another important complication is, of course, thromboembolic events. It's caused by an embolism of thrombus or air, so sheet management, and the anticoagulation during the procedure is important for that. This happens typically in the first 24 hours, but patients are still at risk up to 2 weeks after it. So that's also the reason why anticoagulation is prescribed the first 2 months, regardless of the CHA2DS2-VASc score. If you have an air embolism like you see on the picture here on the MRI of the brain, and in a multifocal way, then we have to rule out another important life-threatening complication. Anybody? Atrioesophageal fistula. This is caused by direct caused by the thermal damage of the esophageal wall and the esophagus that is directly posterior to the posterior left atrial wall. Typically, the presentation can be delayed and aspecific, so patient can present at the emergency department weeks after the procedure with hematemesis, sepsis, or a stroke. And surgery as a treatment is really important to do it before neurological damage. Other complication, I go a bit quicker over it, is pulmonary vein stenosis. It's something of back of the days when we delivered radiofrequency ablation to ostial or even inside the veins focally. And it's typically also something that is present delayed after the procedure. Patient can come with dyspnea, hemoptysis, cough. And together with the image on the X-ray that will give a lung infarction, can it be misdiagnosed as pneumonia, lung embolism, or even lung cancer. Another complication is phrenic nerve palsy, caused by, again, direct thermal injury, more described in cryoballoon ablation. Patients can be asymptomatic, but can also be symptomatic with cough, hiccup, dyspnea. But the good thing is that most of the cases, they recover in time. So I go really quickly over the last complications because for me it's something of the past actually. We moved over to the era of pulse field ablation, and we see less and less of these complications. Pulse field ablation give more a cardiac specific effect and less collateral damage. So this is a study with a huge experience of more than 17,000 patients for more than 100 centers. There was no occurrence of atrial esophageal fistula, no PV stenosis, no phrenic nerve palsy. If you see good, then you see also that the occurrence of tamponade and stroke and TIA was really on the lower side. So the lesion itself, due to the pulse field ablation, is less thrombogenic and gives less inflammation. Last complication I want to mention is the vascular complication. This is nothing to do with the technology, with the ablation itself, but is due to the vein puncture. And we evaluated this in our cryoballoon ablation patients, where we introduced increasingly the vascular ultrasound. If you look at the first group, that was the group where we didn't use the ultrasound yet. The historical cohort, the blue bar, we had 1.7% of major clinical events, meaning defined by the events that required an intervention or a prolonged hospital stay. What we saw in this 1.7% of clinical events, we saw that 50% of them were delayed presentations, median 24 days after the procedure. So these were pseudoaneurysms that were clinically missed the day at the discharge. If we look at the second group, these were patients that underwent only ultrasound after the procedure, the day after. We could decrease, that is the red bar, we could decrease the major clinical events up to 1.1%. And this was driven mostly by the fact that we had no delayed presentations anymore. And then the last bar, there is no bar anymore. That was the group where we used the ultrasound for puncturing itself. Then we saw in this group we didn't see any major event anymore. So we can now say that that by introducing the vascular ultrasound, we near zero the risk of vascular complications. So how to prevent complications in general? I think operator experience is still important. The volume of the center, systematically, low volume centers have higher rate of complications. The use of imaging is important for access. Ultrasound, vascular ultrasound for the groin puncture. Echocardiography for the transeptal puncture, transesophageal or intracardiac. For preventing thromboembolic events, I think anticoagulation protocol is important. Uninterrupted anticoagulation is proved to be safe in randomized controlled trials. And we give extra heparin, of course, during the procedure. Like I already said, the energy source is important. We move over steadily to more non-thermal ablation, where we see now less collateral damage. And there's also something to say about the catheter design. If you look at this picture, where you see a cryoballoon, and on the left, and a Varapulse in flower mode in the middle. And you look now at this picture, don't look at the circular mapping catheter, but at a stiff pointy catheter, ablation catheter, that is moving in a structure in a thin-walled left atrium. Then it's quite clear that the first catheters move a bit more naturally in the heart. So I think, we go more and more towards more safer tools, safer energy delivery. But I think more importantly even is the structure behind. We cannot just do the procedure and leave the patient alone then. I think we should continue the integrated approach with everybody included, GPs, referrals, emergency doctors, and nurses, etc. So thank you very much.